Welcome to the Nervous Breakdown podcast. Today we're going to be covering Mounjaro, all of its benefits, risks, side effects, how it acts, what it is, where did it come from, everything from impacts on society, local commissioning bodies and the overall National Health Service, and the long-term outcomes as well for patients from studies, trial data we're going to be bringing up. So today it's just going to be an overlook of all the good science and data we have on this, and we're going to have a more integrated episode with a few experts on the channel in the next few weeks as well on Mounjaro. Now, what is Mounjaro? Where did it come from? Let's get some backstory here. So Mounjaro is a drug developed by Eli Lilly, a pharmaceutical company, and just like any drug, it will bind to a receptor to have a certain effect. In this example, it will bind to and act on two gut hormones in particular. When it acts on those hormones, it will activate them. It's an agonist, and these hormones will then bind to other receptors elsewhere in the body and have their effect. So Mounjaro is much debated across the health community, even the fitness community, because of the very controversial but characteristic side effect of weight loss. It's actually classed as a side effect, not even a benefit. The benefits come with the reducal of the prevalence of diseases like cardiovascular disease, which we'll get into as well. So, let's get some more backstory. When did this come about? Who had this idea? All these things. So, initially, about 100 years ago in the 1930s, they developed a quite harmful drug called dinitrophenol, which increased metabolism, and it had very severe effects and deaths. So they pulled that out. Then in the 70s, they started to go into amphetamines, which we know is going to be very risky because it will have effects on the brain, dopamine receptors, and something we know from amphetamines is that they're also highly addictive, and their effect is reduced over time. You begin to build tolerance for the drug. So all drugs will have some level of tolerance that the body builds up to it, but for amphetamines it was a crazy amount. So they pulled that out. And in the 1980s here, a scientist called John Pisano, and a few others as well, John Pierre Ruffman, started to look into a type of venom, Exendin 4, which was similar to the GLP-1 hormone. So this is not so important to know, but it's kind of getting an idea that this drug was developed to act initially on the hormone. It wasn't magically invented or magically discovered to have this effect because of that. No. They started to look into GLP-1, and specific scientists, Joel Habeneer, Svetlana Mojov, these scientists looked more so into GLP-1 and found that its effects were multiple in the body, including improving diabetes, helping with insulin resistance, helping with weight loss as well. So Ozempic was the initial drug that was marketed under the name of Wegovy. That was the pharmaceutical behind. And it initially just acted on GLP-1. It was a GLP-1 agonist, which is glycogen-like peptide. And we might not get so bogged down in the exact medicine today, but it could be important to know. We'll get into it later on, what that does. And Mounjaro is the second stage, where it acts on two gut hormones, GLP-1 and GIP, which is glucagon or gluco-insulinotropic. That's the key part, insulinotropic peptide as well. So let's get into what it is. So it's a GLP-1 agonist, as we mentioned as well. It has effects on obesity, weight loss, drugs. We'll get into how that works specifically. And the compound itself is tirzepatide, Semaglutide is the initial, as you can see here, of Ozempic, but this is tirzepatide, and it has a dual effect. We'll get into why that's also important later. So let's take a look at this molecule. Here we have ester groups, amide groups, amine groups, benzene groups. And this is a very complex molecule, as you can see. But remember, it has to act on a hormone, and hormones are also complex proteins as well. They're not always proteins, but usually they are. So it will act on this hormone, and GLP-1 has the specific effect of slowing gastric emptying. So that was the key idea that I hadn't quite mentioned yet. So it slows gastric emptying. GLP-1 has also effects elsewhere, like in the brain, and we'll get on to why that could be important as well. But just remember, it slows gastric emptying. Why is that an advantage? If you slow gastric emptying, which is the time it takes, the time food stays in your stomach, then it gives the impression of you being full. So it increases satiety a lot and also interacts with the brain to do that, and it makes you feel full. Obviously, this will have problems as well, such as nausea and vomiting. So these are just the short-term side effects. That's why I'm mentioning them now, because they're not so important. Everyone will have this nausea, but we'll get on to the long-term as well. So it's this tirzepatide. Now, what is its impact? Local, national, and all these issues down here below. Well, on a local level, local commissioning bodies have to be very careful because they are ultimately going to be controlled by the NHS and the NHS budget. The NHS will have 4 main reasons it will struggle to deliver this drug to everyone based on clinical need, which is going to be this first pillar here of equity as well. So equity is the ability to prioritize based on clinical need. And the main reason it's going to be difficult to give full accessibility initially is because of 4 things. First of all is the NHS budget. Funding generally from the government is limited, and it has to contribute to other innovations and therapies that might be more proven or more well studied or more critical even, such as cancer research. Now, the second one is going to be something you might not have thought of, but workforce. Think about it. To bring a drug to market, you need a workforce involved, you need systematic systems with trained clinicians, you need infrastructure to be able to deliver the drug, you need logistics, you need to be able to monitor and manage patients over a long period of time, do studies, trials as well, following this, which also adds to the budget component as well. So workforce, systematic issues, and the funding. The other 2 things is patient safety. So patient safety is very critical here. And the 4th thing will be generally, we'll get onto that. So patient safety is critical because you don't want to give full accessibility for a drug that we don't know the long-term effects of. This is not a simple ibuprofen or anything like that. This does have serious side effects we've already seen, and it also has serious effects which are deemed positive but might not be positive for certain individuals, namely weight loss for people who have a BMI in a healthy range from 20 to 30. So how do they prioritize patient safety? Well, what the NHS does is they do a rollout. A rollout is a planned phased introduction. So they plan this in advance to be able to bring certain amounts, limited amounts initially, to those in the highest clinical need for the drug into the market so people can access them with proper selection criteria involved as well. So they want to bring this in so that only the people who really need it can take it, and we can examine the effects. Now, the drug has been only studied, Ozempic specifically is the 1st generation, and that was only studied for diabetes. We only have long-term data, even on Mounjaro. The only long-term data we have is for diabetes-related conditions, namely seeing insulin resistance, how it improved over time, and we'll get onto studies of that. So we also don't know the long-term complications, so we need to prioritize patient safety in this sense. We don't know the effect it's going to have on non-diabetics, and we don't know the effect it's going to have on the general population as well. And the other reason is if you increase accessibility, people who might not need the drug will get hands on it, but also distribution might be going through the wrong channels as well. People who might need the drug might struggle to get the drug, but then again, if there's not enough access, they might also struggle to get the drug. And we'll get onto a specific reason why they might already be struggling because of this rollout, which is supposed to be for patient safety, workforce, and NHS funding and budget as well. So part of the patient safety will be the 4th reason as well, which is to target the drug appropriately for those who have the highest clinical need, who also have a risk-benefit assessment hopefully conducted to see the long-term progression of the drug and how it might be more beneficial, because you don't want to be prescribing the drug to someone who's going to be taking on more of the risks compared to the potential benefits they may gain from it. And also making sure it's for the highest risk patients and that all the outcomes are favourable long-term. So one of the issues we have right now on a national scale but also on a local scale is already these issues with funding, budgets, resource allocation, and this key idea of resource allocation has become a problem because of what is known as the postcode lottery. So what is the postcode lottery? It means, and it happens with all drugs everywhere, that certain areas of the country or certain populations, whatever, certain regions, will have greater accessibility to the drug over other regions due to more resources, higher population, or better infrastructure. So the concentrated hubs and cities, especially in London, potentially Manchester, these places might have greater access to the drug, availability, might have more trained clinicians, more funding, more allocated resources because of the population. But other deprived areas in the southwest far north in the country might have less. As well as that, two specific examples of this is Coventry and Warwickshire, which you might know fairly well as areas, but they're actually very low income areas. So even if they have a decent population, that doesn't matter if it's low income, because you won't have many trained people. You might have high crime rate. You might not have people going into becoming a doctor, being able to help deliver this drug everywhere, to help people manage the patients, and the patients themselves could not even afford it. This drug, or Ozempic at least, costs about $800 in the US and about £300 in the UK. Mounjaro might be a little bit more expensive than that, but it's probably going to be a similar amount. So this is going to affect everyone on a national scale, because it means certain areas will get it over others. And there's been some statistics with this as well. Only 9 of the 22, or I think there might have been more as well, 30 or so, funding bodies to give this drug were able to give it for their associated region. Okay, ICBs is what they call them, Integrated Care Boards. Only 9 were able to make it available for at least 70% of their patients, so make it greatly available. It was available in other regions, but even in Coventry and Warwickshire, less than 25% of eligible patients were gaining access to the drug. So this is a very big issue, because it means, first of all, people are not getting the drug who need it, which infringes on justice. People who have the same level of risk and condition, like type 2 diabetes or morbid obesity, do not have access, so they don't get standard treatment. But also equity. People in Manchester, for example, might have greater accessibility, so people with lower criteria or on the lower range of the selection criteria to pass will gain access to the drug who might not need it as much, or might not have as much perceived benefit compared to the risk they're taking on. So privatisation is also going to be an issue in this. Not only are you struggling to make it available to everyone with the rollout, even though it's supposed to be phased and have a specific purpose for those 3-4 reasons, but also people might get it through online pharmacies, private doctors, private NHS. In fact, 90% of all Mounjaro prescriptions have been given privately at the moment. Only 10% of eligible patients going through public methods. So everyone's having to pay. And that's a huge problem. And in the US, it's going to be an even greater problem because of the fact that their healthcare is not government funded and is primarily private. Other areas as well, like Australia, will have a similar issue. So how do we combat that? Well, we have to make the rollout more accessible. We have to improve resource allocation, slowly but surely, as well. Improve the NHS budget as well. Obviously, this is going to be a difficult task, but things like cutting down on working, like unnecessary spending, staffing hours, projects that aren't giving specific results, and trying to prioritize more so to these weight loss drugs. Why would we do that? Well, this is a huge problem. In fact, 19 to 20 billion pounds is spent just on weight-related conditions alone in the NHS, whether that be diabetes, obesity, or anything else. So this is a huge issue spanning the entire country. So it must be tackled, and there is definitely a place for these weight loss drugs. Now, 2 things I'm going to mention here as we get into the next one, the risk-benefit assessment. So let's talk about how this is prescribed, how we go about giving this drug, and how these processes align. So here we have some data on how this is usually given. So this is given subcutaneously. There will be oral pills as well in the future, and they are being developed, but that might have not as strong of an effect because of two things. First of all, it can be more easily metabolized, and second of all, which is similar to that, it'll have a lower bioavailability. We won't get too medical in this, but bioavailability is just the amount of the drug that can be efficiently absorbed into the bloodstream to have its effect. So if I administer something through IV, into the blood directly, it's going to have 100% bioavailability. And subcutaneous may not have 100%, but it's going to have a very strong effect in that area. And also, why is it subcutaneous and not IV, you might ask? Well, for it to be IV, you need a hospital. And this is a very interesting concept in healthcare, which is quite well known. You need a hospital to have IV because you need to insert a cannula, you need to do everything safely. But subcutaneous, you can do the injection yourself, which is why people do it, why people are able to take it themselves. So the recommended dose subcutaneously is 2.5 milligrams once weekly. So it's not a lot, but it does have its effect over time, and you don't need to have a huge effect when you're acting on a hormone that naturally acts in the body on various different areas as well, such as GLP-1 and also GIP. So yeah, glucose-dependent insulinotropic polypeptide, that's the exact name. And glucagon-like peptide. Sorry, glucagon-like peptide, not glycogen-like. So it will almost mimic the effects of glucagon in a way. If you don't know the parallels, insulin is going to increase when the blood sugar levels increase after a meal. And insulin's role is going to be to bind to insulin-dependent cells, liver and muscle, to take up glucose. It does that with a second messenger model binding to the surface of the membrane of the cell, and then expressing, keyword expressing, bringing to surface those glucose transporters, what allow it to go through, or glut transporters, allowing glucose in. So many issues can arise from that, which I'll go through in a second. But there's a lot of guidance around this and a lot of FDA recommendations and provisions as well. Safeguarding is a very important principle of the rollout as well. So adults, 15 milligrams subcutaneous once weekly, which is what you're trying to work up to. So this is called titrating up the dose to have a stronger effect. First of all, it's going to be a big shock to the system if you go immediately 15 milligrams. So you start with a lower one, keep increasing. So 2.5, then they recommend after 4 weeks you go up to 5 milligrams and work your way up all the way to 15. Pediatric patients under 10 years or 10 years of age or older will be using it with 10 milligrams subcutaneous once weekly. But they're pediatric. This is a huge risk to take on for a child. And we're seeing nowadays, obesity was very uncommon as an issue in the 80s or 90s. People were in great shape, they were exercising, dieting, but modern society, consumerism, all these things have really impacted us. So obesity is very highly prevalent. In fact, in the US, it's even worse. So in the UK, 64% of all adults are overweight. But in the US, it's 80% or higher. So this is a very big problem, as you can imagine. 50% are obese just in the UK. And people are getting younger and younger obese as well. Not just because of complications like they might have Cushing's disease, which is a bit more complex to understand. But general diet, changes in lifestyle, all these things are having huge impacts, and diet is the big one, especially in the US, because of what is marketed and the portion sizes as well. But even here, we struggle to get whole foods, naturally sourced foods, good vitamins, good minerals, even good sunlight, good diet and exercise. And why is exercise so important? This is one of these steps to understanding this, because you need to take this in stages. There's going to be like 3 or 4 levels for weight loss. The first is going to be the preventative side, which should be most heavily pushed. You've got things like diet, exercise, sleep, of course, low stress, lowering your stress levels as well. That can have an impact on weight gain. And this is the first approach. The second, when that hasn't worked and you need to make sure that's exhausted because of patient safety, you link back again. Because why would I give someone a drug when clearly a small diet and some exercise could have a huge effect on them? But those people who have deviated too far from their ideal weight range and have exhausted those methods haven't worked. The second would be to manage the associated condition or disorder in a light way, such as prescribing metformin, which is a very well commonly used drug. And a third level is these weight loss drugs, and finally bariatric surgery if it's very critical. But yeah, what are the selection criteria to get this drug. You need to have a BMI, initially it was said to be BMI over 40 and at least 4 other comorbidities, which are weight-related conditions like diabetes, hypertension, high insulin resistance will be part of this as well, which is a very important measure because BMI doesn't give the full picture. But now the criteria is dropping to around BMI 35 and other weight-related conditions because of the rollout, comorbidities as they call them. And having high weight causes many problems: hypertension, increased cardiovascular risk, kidney failure. So one of the huge benefits of the drug is tackling these circumstances. So weight loss specifically will reduce the risk of cardiovascular disease. In fact, the drug Mounjaro has been proven clinically to reduce cardiovascular events, acute cardiovascular events, by 20% in the following few years after taking them. And the other one is going to be insulin resistance, very important in diabetes, because insulin resistance does what? If I can't get glucose into cells, insulin dependent ones, it's going to start going into other cells, okay? Namely, it's going to be deposited in fat cells, which is going to increase your weight. So decreasing insulin resistance will help you lose weight, which will have many very good effects. Improves sleep quality as well. You might have sleep apnea, hypertension, all these things. But also, it will go into 4 key cells which can cause huge damage. First is into the brain itself, crossing the blood-brain barrier. Second is into neurons across the body. Third is into kidney cells. And fourth is into the eye. So these are the 4 actually conditions associated with diabetes. You've got diabetic neuropathy, part of the brain and the nerves as well. And it could be elsewhere in the body. In your arm you can get it. Diabetic retinopathy in the eyes, where the retina starts to become damaged because of too high glucose. And also diabetic nephropathy for the kidneys. So yeah, very important to know all these. And the risk-benefit assessment, those are the benefits potentially. It can greatly reduce someone's weight loss. It can improve their lifestyle. If it's coupled with diet and exercise, it can greatly improve their physical condition, extend their lifespan. And in fact, having obesity has been shown to reduce your lifespan by 15 years. So if an average male or female is living about 80 years, they're going to die by 65 with obesity. So this is a very problematic condition. Now the risks. We're going to get onto the main risks associated, approved, in a second, but things to mention are the inflammation that it will cause. It's going to be acting on hormones, namely will have an effect on the gut, so GI hormones. You might have some adverse reactions as well. You might have the pancreas involved as well, we'll get onto that. And inflammation generally, obviously the short-term effects as well. But also it can have an effect on the reward centers of the brain, and this is up-and-coming emerging research. It acts on the hypothalamus as well in the brain, and the cerebellum as well. And you can have associated problems with this, because these are responsible for your reward centers, being able to derive pleasure from food. Dopamine receptors will be there as well. And also coordinating satiety with the pituitary gland having an impact as well. And even with your emotional centers in your limbic system in the brain. So if you're affecting this, obviously we'll get into this way more in depth when we bring the experts on. But it can dampen your associated reward with food, which people have noticed generally when they're taking the drug. Now this is emerging and there haven't been any significant studies on it yet, but we're getting there. Obviously things take time, and even to get this drug into market, they've gone through phase 3 trials, blind trials, double-blind, randomized, multi-test center, all these things. So you do a risk-benefit assessment for the patient. Are they in a healthy BMI range, in which case they shouldn't be taking the drug? In fact, there's been stories of people developing neuropathy because of the drug, because it removes the weight very rapidly. It can also cause you to lose muscle. This is a very big thing with weight loss. It's both fat and muscle. It doesn't say fat loss, it says weight loss. So people who if they have no muscle, that's still a bit naive to say you will lose muscle, and this can cause things like sarcopenia in the future and really rapidly degenerate your strength, especially when you grow older. So this is very critical when taking these drugs. You should be exercising. You should try and bring yourself off the drugs, titrating down as they call it, and bring in those preventative measures. And it's actually been shown that people who come off Mounjaro regain on average 70% of the weight they gained because of a lack of discipline, commitment to this drug, or even their body cannot fully adapt and they need the drug. So this is very risky with the drug because you can't come off it, and now we're going to get into the side effects, why it's bad to stay on it. So the top three: thyroid cancer, pancreatitis, hypoglycemia. Let me just preface this by saying hypoglycemia is primarily seen in Ozempic. What is the difference? Well, Ozempic acts on GLP-1 only. So when you inject it, it immediately increases GLP-1 in the body to have its associated effects. But acting on GIP with Mounjaro has the effect of making it specific to when insulin is higher in the body, because it permits insulin. It doesn't create it, it permits it. So because of that, hypoglycemia is less of a risk because it only increases the GLP-1 for insulin to be more effective when insulin is higher in the body, when it needs to act. So this is less of a risk, but it's more so seen with Ozempic. Now, here's some of the dopamine pathways it can interact with as well, as we mentioned here with the brain. But now the main two: thyroid cancer and pancreatitis. So it's been proven to increase the risk of thyroid cancer by up to 50% because it is influencing your metabolism, the way you process and digest food, and the way your body functions. So that can lead to inflammation and cancer as well. We've seen that. And I'll show you some sources at the end. I'll put those there in case you don't trust me, of course. And then pancreatitis as well. Some studies have shown up to a 9-fold increase in pancreatitis. So although it's a rare condition, we are greatly increasing the risk of developing a pancreas-related inflammation or cancer. And this actually comes in the official FDA recommendations when you look at it. Now, so they've actually shown to have developed thyroid C-cell tumors. This has been shown in rats when on this drug, but we don't have much data for humans just yet. But that's still quite concerning. So the other associated warnings, the main ones, are going to be acute pancreatitis, GLP-1 receptor agonists, hypoglycemia with concomitant use of insulin. Okay, so if you use insulin, it can cause hypoglycemia because it will greatly increase glucose into the cells, removing it from the bloodstream. Hypersensitivity to reactions, anaphylaxis have been also reported. Acute kidney injury. So this is a key one. If I'm slowing gastric emptying, which is the main way GLP-1 acts, then I'm going to have less renal perfusion, more dehydration, more fluid loss, acute kidney injury. These kind of things might happen as well if I'm slowing down the digestive tract to absorb all these foods. So it could even aggravate this condition if you already have some kidney failure present, like CKD, chronic kidney disease, for example. Acute gallbladder disease, diabetic retinopathy. Oh, so it can actually increase the complications. So if someone has a history of diabetic retinopathy, then not recommending this drug. So there are a few complications that are actually going to mean that the drug has worse effects on the person, namely the diabetic conditions, the critical ones like the kidney failure and the retinopathy, as you can see here, and even neuropathy would also be a risk, and pulmonary aspiration. Okay, so drug interactions, delays gastric emptying, potential to impact the absorption of concomitantly administered oral medications. So it can interact with other oral medications, decrease, metabolize them faster, decrease their ability to act in the body as well. So, now, obviously this is going to be changing with new research, new studies we do. Hopefully we can understand more of the medicine behind this. We'll have another episode, don't worry, in a few weeks where we'll discuss this more in depth. Let's move on to the statistics. So, let's get through this quickly because this might look very intimidating. The first, right in the center here, we're looking. Percentage change in body weight by week. This is the easiest one to understand. People who took a placebo roughly saw a 2.4% decrease in their body weight, and this was done for people with an average baseline weight of 105 kilograms. So that's already in the obese category. I can almost safely assume that already, and with a bit of uncertainty, but as you can see, the uncertainties do not overlap for any of these except at the bottom when you get to higher and higher doses. So even with just 5 milligrams once weekly of tirzepatide, we see a 16% change in body weight. Ozempic has been shown to have an 18% in its correct dosage effect. Mounjaro in its correct dosages, which is usually around 10 to 15 milligrams, as you can see here, because we have a 21.4% reduction and a 22.5% reduction on average. But the standard deviations do overlap. What does that mean? That means the data is not statistically significant. So the actual differences in the 10 milligram and 15 milligram doses are not so big in terms of weight loss. But as you see, this is a huge change in weight loss. Not just reducing fat, but reducing your actual body weight by 1/5 or more. And there's going to be a new class called triple G, which will act on 3 gut hormones, that has up to a 24% reduction in body weight. Weeks since randomization, you have all that data. So you can see initially has a very drastic effect in the first 24 weeks, the drug itself. The placebo also shows that, but it also tapers around there. But yeah, even after 24 weeks, at 5 milligrams, it tapers quicker. The other ones keep going. So you're already seeing a 15% reduction with 10 to 15 milligrams in the first 24 weeks. So less than half a year, that's like 4 or 5 months. Now, let's go to the right. Let's go through this quickly. Changing glycated hemoglobin levels. So to understand their targets with glucose, they did a glycated hemoglobin test. So the glycated hemoglobin test is going to test for the presence of glucose on hemoglobin, which will bind. And this will show blood glucose concentration. So it will show over time if people have improved with the condition, which it has shown compared to the placebo. Not by a significant amount, though, you could say. And, right here, 6.42%, 5%. So it's improving the balance of blood glucose, which can help with diabetes and pre-diabetes related conditions as well. Serum glucose levels, they are decreasing faster after a meal, which is also good. It's meaning more is taken into cells, stored for energy, healthily, and more fats are hopefully being burned. That's the ultimate goal, to lose weight, which is through loss of fat and some muscle as well. And then hemoglobin targets as well. So these are the targets for their weight loss, actually measured through this glycated level. Now, change in body weight. As you can see here, very significant. Again, up to 20% with the treatment regimen. Efficacy up to 22% we can see with tirzepatide compared to the placebo at 2%. So it's definitely very effective. Change in body weight here, you can see more data. And the incidence of type 2 diabetes. Those cumulative incidence is very low with people who have been pooled using tirzepatide as well, as you can see here. But with the placebo, especially in the off-treatment period, the incidence increases and it goes from 0 all the way up to 16 to 18%. So it's still present. Long-term outcomes, let's get to this. Let's get through this a bit quickly. What are we seeing over a long-term scale? Well, this is going to become much more accessible in the public. The rollouts will be coming out faster. It's going to be heavily marketed, I presume. Might not be the case. Might be held back a lot. Might be restricted for patient safety reasons. But hopefully it will have the vision of improving healthcare, as you can see in the corner there. And make this a viable option for people, but also have it with, make it aware to them, have more knowledge around this with more studies, data, to see the long-term outcomes associated with this condition, its benefits, and on a long-term scale, how patients react to this, how they take it on. Hopefully we'll see in non-diabetics no ridiculous side effects or increased risk in when they're 20 years older, 30 years older. Hopefully it'll have a very good impact on people with associated obesity-relevant conditions. The risk-benefit assessments, hopefully those are conducted very well. But over time, the Mounjaro market, because of this popularity, especially in the US, in the UK, I would like to think it's a bit more controlled. But in the US, it's projected to go all the way up to $41 billion in the next 10 years. And it's already sitting at $8 to $10 billion here, $10 billion as of now. Who really knows the long-term impacts of these drugs? It might be pulled, it might be accelerated, more likely to be accelerated. It might become a growing transformation in people, helping reduce weight. But once again, it's not going to be a silver bullet to weight loss. It's going to be additive and an additional measure with classic diet and exercise, and improving your lifestyle as well. How do you expect to improve your condition without improving the way you live and treat your body as well? So, these are the sources. You can take a look. Hope you've enjoyed this video. Stay tuned for the next one, the bigger one. Actually, it'll probably be as big as this, as long as this. This is a very good breakdown we've done today. We've covered everything about the drug, all the impacts, all the science, all the risks. But yeah, stay tuned. Hopefully we'll have an integrated discussion with a few experts, and these are the sources. You've got cancers, articles about the use of this in diabetes patients. We've also got thyroid cancer, FDA access data for how the drug is prescribed. Very important to check if you want to actually take the drug. But once again, I would want you to check the selection criteria and the potential risks and benefits. Hopefully your doctor will explain that to you. Nature as well, an article on long-term effects, studies, the statistics as well came from there. Guardian as well, the impact of postcode lottery, the weight loss over the 3 years, and the actual pharmaceutical company, their data as well regarding this. So yeah, thank you for watching everyone. Hope you have a good evening, and I'll see you in the next video.